Hello and welcome everybody to the No Normal Show for Thursday, September 24th, 2020, brought to you by Revive Health. This is our weekly deep dive into how hospital health system marketers can navigate what we are calling the no normal. I am Chris Bevelo, Health Systems Practice Lead at Revive Health and your host for the show. I'm joined today by Chase Kleckner, who is Senior Marketing Manager at Revive Health and our show's producer. Hello, Chase.
Hey, Chris. Good to see you as always.
Good to see you too as well. And we are so thrilled to also be joined today by Dr. Robert Winn, who is a nationally recognized leader in addressing health disparities and is also director of VCU's Massey Cancer Center. He's a principal investigator on several community-based projects funded by the NIH and National Cancer Institute to help empower underserved patient populations, improve healthcare delivery, and ensure equal access to cancer care. Hello, Dr. Winn.
How are you? Great to be on the show.
So glad that you're with us. Now, is it okay to call you Robert, Rob, Dr. Winn? What do you prefer?
Rob would be fine.
Rob. Okay, perfect. Well, Rob, we're really excited to dive in. Let me get through some housekeeping notes here at the upfront, and then we're just going to get right into it. So for those of you who haven't been on the show before in this podcast, we share trends, research, stories from people like Rob or others, anything to help health system marketers and communicators navigate what we call the no normal successfully. If you want to understand what we mean by that, the no normal, key principles of that, check out our blog post. Chase will post that in the chat function. Speaking of Zoom and the tools that we have for Zoom, if you have a question for Rob or myself or Chase as we go through this show, please put those in the Q&A function in Zoom. Put them in the queue there. You can use the chat function if you want to talk to other attendees live who are with you here. Also, again, Chase will be using the chat function to put forward any links of things we're referencing. But if you want us to answer a question, which we'll have plenty of time for, please put that in the Q&A queue, and we'll keep an eye on those and get to those as we can, if not at the end of the show. Remember also that you can subscribe to this podcast on iTunes or wherever you listen to podcasts. And as always, we post a recording of the video version of this episode on our website by the end of the day. You can find that at thinkrevivehealth.com/COVID-19. And with that, that is the shortest intro I've ever given because I want to get right into this, Rob. Just so excited to have you here. So let's just start with you. Why don't you give folks a little bit of your background, who you are, what you've been doing with yourself and how you came to be where you're at VCU and focused on things like health disparities.
Yeah, so I would say that I'm first and foremost really dedicated to making certain that as we come up with miracle drugs and these things, that they are distributed to the greatest number of people. And so from a philosophical sort of perspective, I would sort of say that instead of a Carl Benz sort of model where he came up with the first combustible engine and that's a miracle for everyone. I mean, it was an advancement forward. I probably would sort of say I'm more like the Dodge brothers in the context of really trying to figure out how do we get these great things to the greatest number of people? So that's been an interest. For the sake of transparency, I have not always been a sort of person that does implementation science or what we call health delivery sciences. That has been an evolution. I currently still run a lab. My passion was really in signaling, particularly RNA binding proteins and which, to be quite honest with you, is bringing sexy back. This is another talk for another show. I have always sort of said that if loving science is wrong, then I really don't want to be right. But because I think that there are some wonderful aspects of basic sciences that have led to some of the amazing miracle drugs that we have now. The issue is that I don't want to stop short and have been cognizant over my entire career that sometimes the really great minds from our bench scientists really could, would have the initial knowledge that creates the drugs, but then it stops short of getting to particularly sometimes the most at-risk populations. And so over time, I've had to evolve into making sure that I bring both those pieces together. And just so you know, I am the product of a 15-year-old mom. I'm a Head Start kid, if that means anything to anybody. That was the Julian Richmond program to give at-risk kids like me a head start. I will tell you that I am a champion of federal programs. I think that those programs allow me to be in the pipeline, have supported me throughout my career to the point where I've gone from Head Start kid to cancer center director, and the only African-American cancer center director currently of a NCI designated cancer center in the United States. So that's a little short synopsis. In between,
Wow,
there was Notre Dame and Michigan and all the rest of that stuff, but I figured this is the big overall picture.
It looks like we lost Chris. Chris, are you there? Let's see if we can get Chris back. 1 second.
I may have talked too much.
Who knows what happened there? Well, how about this? How about I know Chris had another question for you. From an overarching perspective, how would you define health disparities?
Yeah, I think health disparities is easier defining what good art is. And the reality is when health disparities by definition means when you have two populations that theoretically should be getting the equal amount of care and they're having different outcomes. An example of that is in lung cancer. We know that African-American men actually die at a greater rate than their Caucasian counterparts. That by definition are disparities. So when I look at health disparities, I don't look at health disparities as either being positive or negative. I just recognize that they are. That's the data. And I think sometimes when we deal issues around health disparities, there's almost emotional sort of attachment that we immediately go to race, we immediately go to all these other things. I had done work with folks under the Obama administration in Cuba, and even sort of said in Cuba that there are clearly disparities. There may be a difference of people dying from lung cancer in one region of Matanza versus that in the area of Havana, and that is a disparities. And so by definition, it means when there are just different outcomes when theoretically there shouldn't be. And the only other thing I'll say about disparities research that usually is a lightning rod is that people want to actually then blame, say in this case, African-American men. Well, there must be something with African-American men. I will tell you that for me, your zip code and neighborhood of association is probably the bigger predictor of your outcome than your DNA. And I'm not saying that it's either or, I'm saying it's and. It's understanding the basic science part of our DNA, but it's also understanding the structures that actually impact that DNA, either by example, stress and other epigenetic type things about lack of access to food in the microbiome, stress and the impact it has on the epigenetics of cancer may actually, because you're living in a particular neighborhood, increase your risk, not because so much of your DNA, but because of the interplay between where you live and that DNA. And I think that we need to grow up a little bit as we're talking about health disparities and not make it this fairly superficial conversation that we typically have.
Yeah. It's such a good point. I think for me, Rob, when it comes to Richmond, which is where you're based out of, how have we seen COVID impact these health disparities? What's the conversation there? I mean, obviously it's a big conversation. I think that came up a couple months ago, but it's still true. What's been the impact as far as COVID-19 for health disparities? So
COVID has done us the favor of, for example, race and racism is a little bit like, and health disparities have been a little bit like chasing the Yeti. So I could say, or the abominable snowman, I've seen the Yeti and I'm the abominable snowman, and I'm telling you firsthand experience that I've seen it. But others who have not been exposed to the Yeti or the abominable snowman run around like, oh yeah, this is just that George Floyd piece in the backdrop of COVID made it impossible for most of us to ignore the Yeti and the abominable snowman because we finally saw it for our own eyes. So COVID really has, people sort of say, amplified or put a spotlight on this. I would sort of say it was COVID and some of the social unrest that made it very difficult now to turn away from. I'd also add that maybe for the first time, because we're so much on the go and about immediacy and quick answers and quick this, that it's the first time in a very long time that all of us were at a place in a space where we were quiet for a moment and we couldn't turn our attention to be distracted to something else. So I think that it's a combination of the social issues that we have had, the unrest, along with COVID, that have made this impossible to sort of turn away from, and certainly impossible to not be somehow impacted by.
Yeah. Well, yeah. Chris, it looks like we have you back on the line. Is that true?
Of course, yes. I'm back. I'm back. Audio only. Can you guys hear me?
Yeah.
Okay.
We can.
Gotcha.
Yes, my internet is completely out. Of course, it dropped completely 5 minutes into the show, so apologize for that. But I heard most of what you were saying, Rob. There, I picked up on the Yeti metaphor. So let me ask you, given what you just said about COVID-19 and kind of how it's that and the social issues that we faced since George Floyd in May. How do you see that playing with the next issue related to this in all ways, which is the release at some point of a vaccine? Given what you said early on about science and the importance of science, and we have seen how the vaccine has been beaten around like a beach ball politically. Certainly how the vaccine is distributed plays into the issue of health disparities. What are your thoughts on that?
Well, it's a very interesting question. And I will tell you that it's been more difficult. Ever since, and many of you probably that are not in Virginia area are still probably familiar with back in February, we had a faith-based minister named Gerald Glenn. And past Bishop Glenn was famous for saying at that time, all you need is prayer. We don't need any, we're not worried about COVID. All we need is prayer. Long story short, he died of COVID and some people from his congregation as well as family. Why do I saying that? Because since March or since that passing, I have been meeting weekly, committed weekly, every Friday from 3 to 4 with something called a Facts and Faith Friday. Now, why did I do that? Well, and this is getting to where we're going to get to the whole issue around the vaccine, because this becomes important. So up until the last couple of weeks, we had been dealing everything about what COVID is. We were giving them, ideas about how to protect themselves, getting out there with PPE, doing all this wonderful stuff. We even had these these faith-based ministers to the point where we had over 300 of them who were willing to sign up to be part of the vaccine trials. Trust, right? So we were showing up weekly, giving information, bringing information to them from various parts of even the country to so that they can be able to understand what it was that they were telling not only their congregations, but community. Now, people would say, well, I don't understand, there are other communities too. It turns out that I'm going to throw out a phrase that these became overnight anchor institutions. When your libraries were closed and at-risk populations would typically go to the libraries were closed. Mm-hmm. Schools were anchor institutions, they were closed. So many of the anchor institutions that at-risk populations would go to were closed. And so there developed this need to say, well, what were the functional anchor institutions? And interesting enough, the folks that even young people and older people trust were those faith-based leaders. So in working with them, we had them all the way to sort of saying, we know what phase, in fact, they knew probably more than some of my primary care docs in the context of what were the phases of clinical trial. We even talked about how this, the genetically modified, vaccine that's actually happening now was for the first time, that was under the Obama administration, how so these people were packed with information. But these last couple weeks have undermined much of that energy. In fact, the old saying that community trust is gain, you get community trust drop by drop, but you lose it in buckets. Well, we've lost it over the last several weeks in a torrential rainstorm. We've gone from 300 plus ministers or faith-based people of all whatever walks, going from, hey, it's important for us in the African-American community to sort of show leadership in this, to we don't trust anything, including the vaccine. So it's going to be some hard sledging as we move ahead. Rebuilding trust is going to be important.
Yeah, and I mean, we all know about, just in general, before this all came about with COVID, a small minority in terms of vaccine, anti-vax, if you want to call it that, folks not trusting.
Chris, you're going in and out again. Are you there?
Are you guys still there?
Yep, you're there. I've got you now. Or I had you for a second.
So,
Sorry. Are you guys still there?
Yeah, we've got you.
Yeah, oh my goodness. Boy, Rob, more technical issues today than all the shows combined. I don't know what happened. I just all of a sudden had,
you know what? That's just a sign of the weight of the topic.
That's
It is. Well, what I was getting at was, we start with a small minority of people that don't trust vaccines. Now we're at a place, because of some of the things you've referenced in just the situation overall in this country, where far more people are skeptical. Talk a little bit as well about the importance of trust and the difficulty of trust in the African American community beyond just vaccines, but historically the things that have gone on with this government, the United States government, in terms of African Americans, and how that makes it even more difficult in a situation like this, I would assume.
Yeah, and I think as healthcare providers and as people who actually are all part of the healthcare system, we also have to recognize that we've not been without participating in actually having that situation as well. Remember, and these are the critical and crucial conversations that I think that we will have to be able to have to move forward. We've been reluctant to have these conversations as folks either in the insurance field or health provider field, or, however we touch the health system. We've been almost reluctant for decades to have these crucial conversations. But let's start off with the fact that as we think about the very first intro to many of African-American history was in the father of in gynecology, right? Who were doing experiments on African-American women. Why? Because he thought African-American women at the time didn't have pain. And so to do the fistula, right. So let's get it straight that African-Americans in particular, and also Latinos with some of the, early experiments that we had with birth control and some other things that we can get into. But the truth of the matter is, let's not say, Nixon once sort of said, just because he's paranoid doesn't mean people aren't after him. Well, right. I think that there's a similar situation, that the anxiety around most African Americans doesn't date to just the Tuskegee experiments, it's before that. And so as we start thinking about why do we have medical mistrust, it makes some sense. It's built on a foundation of experiences that says we have been treated differently. Now, in your classrooms, we don't talk about that. And as we're developing our health systems, we talk about the sensitivity and cultural appropriate language. But the reality is, what we don't understand is one of the foundational pieces, or the crucial pieces, is to understand this medical mistrust is built on actual mistrust and reasons for it. So these people aren't irrational in their distrust of the system. Second, when you talk about Tuskegee, people don't always go back to 1932 and say, that's not Tuskegee. Tuskegee was one of the sites. In 1932, it's called a 1932 United States Public Health experiment, right? That experiment used African Americans, and I went back in history to kind of vet this out and look at this, and so I've talked with other historians. It was done because African Americans were thought to be close to the apes, and there was no apes with signs of syphilis. So these are difficult things to sort of talk about, but honestly, I think we're better than all of that. I think we're at a point where we can say that was history, but here's how we move forward. But to move forward, we have to understand that it's not, again, blaming the victims and saying, well, they're so irrational about the system. There is a bona fide reason historically dating way back before the Tuskegee studies and then continuing after the Tuskegee studies. The studies that were done in University of Chicago in the context of creating birth control and actually sterilizing some women and giving them without their knowledge wasn't in the 1930s or 40s or 50s. These things have been going on always up until the 70s and 80s. So let's stop playing and act like we don't know the reason why you would have a community at risk and distrustful. The movement forward in building that trust is, first of all, just to admit it. Half the time when people from these neighborhoods, they parachute in and they parachute out. And then they say, I don't understand why these minorities don't want to participate. Come on, man. The reason why I actually do Facts, Faith, and Friday, it was a commitment on a personal level to be there, to show up and to show out and to show up consistently every freaking Friday. Mm-hmm. The truth of the matter is, if you want to win the trust, gain the trust, it's going to be drop by drop. That shouldn't come overnight, and it shouldn't be easily won over, particularly given the history. The question that I have for all of us is, what consistent interactions do we have with the community? And second, what jobs do we provide within our interactions with those communities? And those are two crucial conversations and two crucial questions for any health system to sort of grapple with, so that we can over time gain trust. But I wouldn't trust you. In fact, if I were them, and I am them, I don't even trust us either half the time. And to be quite honest with you, with the recent weeks of the FDA being uncertain about what's truth, what's not, with the CDC, if we as health professionals are actually now almost distrusting the system about what our recommendations are going to be for our patients with the vaccines and other things, how do we expect people in those neighborhoods to just blindly kind of go along with things? So trust is earned.
Yeah, and I think you bring up, there's so many different things we could talk about, Rob. You bring up the recent, kind of, you see the curtain pulled back on the CDC and the FDA and things changing, just out of the blue and changing in ways that are surreptitious, right? So, quietly changing something super important about when you should get tested, not really announcing it, just some Friday afternoon changing that, if you're asymptomatic, you don't have to get tested anymore. Finding out later that was all politically driven. Now you hear, some pushback on what makes a vaccine something that we can trust. And then you have our president yesterday coming out and saying, well, that's, that stricter kind of way to think about a vaccine is politically motivated, which is, it just makes you want to pull your hair out. How do you as a clinician and as a leader at a health system work in your community? Or even let's just start smaller, Rob. How do you work within your organization to try to get to a place where you feel like you have certainty on what's right and what's best for your patients, given all the things that are happening right now?
Yeah, the wonderful part about that is that you just hit the nail on the head, is that the unfortunate politicization of these things has been harmful. However, being in the health system, most of us know that, for example, as a cancer center director, that honestly, whether you're rural or whether you're urban underserved, cancer doesn't care. And in fact, what we have is data on our side. And so what I've been really careful of is trying to illuminate more facts and data. Because the truth of the matter is, when I now go to not only people with inside my organization, but when I go outside into communities, it turns out that we have underestimated consistently what the community cares about. And in fact, it wasn't until I started, and I'll give you a quick example. When I was in Chicago, we have 50 what are called wards, and those wards are, headed by aldermen. When I would go to these aldermen and talk about their cancer health, none of them actually knew the cancer health, or for that matter, the cardiovascular health of the ward that they were overseeing. And these are political figures that actually have resources that could impact. What did I do? 2017, we came up with a way in which we were able to deliver to each of these aldermen really facts about their community. For example, in the 20th ward of Chicago, we found out that while breast cancer was certainly a problem, it was getting better, but prostate cancer in the 20th ward, there were 3 times the number of men dying in the 20th ward than in the United States and the rest of Illinois. Armed with that data and those facts, that alderman was able to influence other community hospitals around the area to work together to start figuring out how to actually address that issue. So I'm going to say to you that it's consistency in showing up, consistency in bringing these issues up, but it's also not just rooted in good feelings, it's also rooted in data collection. And at the start of COVID, remember that we were on our heels from a lot of issues, but the truth of the matter was we were, didn't have the data. And I'm going to say something I know sounds crazy to everybody here, but we're going to talk at-risk populations. And we use at-risk populations sometimes as code word to mean, African-Americans and Latinos, whereas we use rural to mean white. Let's get 2 things straight. In Beattyville, Kentucky, which is a predominantly all-white area, you can see the differences in life expectancy just like that if you were in an African-American underserved at-risk population. So this is not just about race and ethnicity, it's also about class. And that has also been a difficult subject for, I think, us in the health system to sort of grapple with. And so when I also talk about rural, it dawned on me that when we talk about rural, that's code word for white poor, or white and whomever. Turns out that at least in Virginia, there is a substantial population of Virginia, North Carolina, and South Carolina of African Americans and Latinos living in very, very rural. And what I mean by that, the 1 to 10, they're living in a Rooker code of 8 and 9. So let's start having fuller conversations about these disparities issues. And I think it will make it easier as we bring facts to the table to then move forward and gain trust.
Yeah. Yeah. It's just, there's just so many different things. I'm trying to think, Rob, how much further we want to go. I'd really love to hear a lot more on this. I want to get back to a little bit what we talked about before and what we're going to kind of hit on with what you're doing at VCU right now. Can you speak a little bit to some of the things that you're working on in terms of health disparities at VCU?
Absolutely. So one of the first things is we recognize that 2 principles, and I live on 2 principles. This bench to this bench to bedside model we've have proposed and are proponent of for the last 50, 60 years is good. And I will certainly be the first to tell you that there are definitely some good qualities of a bench to bedside model. But the bench to bedside model has some shortcomings. If people can't get to your bedside, then they clearly can't benefit from the work you do at your bench. So we've actually a 21st century model health system is not so much how do people in Chicago take 3 buses and a train to get to me, or in Virginia travel 120 miles to get to me. It is how do we make access to care closer to where people live? Because the truth of the matter is, the closer things are, the more likely they are to use it. So that's a principle that we are now driving here at VCU Massey. How am I doing that? I'm really reaching out to community health centers using federally qualified health centers, which I used to run a network of federally qualified health centers when I was also in Chicago, but learning how to integrate and work with federally qualified health centers, also learning how to work with community hospitals. The truth of the matter is, if you look at the COVID taught me something that I already intuitively knew or thought, but that really brought it to light. That if you look at COVID, those frontline hospitals they got better treatment, obviously, when they made it to the academic hospitals. But where most of the action was actually out in those community hospitals that were woefully underprepared. Not because they're bad people, but because in some cases, we have not come up with an overall strategic plan about really how to buff up those community hospitals so that they can serve people better and be good partners for us as academic medical centers. That's where I'm moving the needle. Issues of making sure that within my community that every grant we get, we are now actually adding, we always call it like in Brazil, like the rainforest. So if you cut down a tree, or in Washington, if you cut down a tree, you got to plant. So every grant now that comes out of VCU Massey, I'm asking the following questions. Good. So how have you actually used part of that grant, or how are you going to use a portion of that grant to actually, hire somebody from that community? Simple question. It's only one job. You're only putting one person on, but over time, if we have consistency of those actions, I think we can actually build a stronger network. And then 3 is you just got to get out. You just got to get out in communities. Interestingly enough, broadband, this issue of virtual is good, but let me just tell you that all virtual ain't the same. In some of my rural areas, their broadband won't even do this. You think you got problems today with getting on those lines. Let me tell you, this is where, right? But that's also true in some risk urban populations as well, that all broadband and all access to virtual is not the same. So I am going to be making a policy move in trying to bring more attention that just like back in the 1930s during the Depression era, there was this, I think it was a national electricity sort of movement where we were just trying to make sure that everybody had access to electricity, and it changed the way we did business in the United States. You're going to continue to hear me sing a note, one of the 14 notes, but one note is going to be improving broadband for all, because access to healthcare these days means access to virtual world, and that is also what COVID has taught me, is that is woefully unequal too.
Well, it just, access has been an issue for a while in healthcare. We know that. And to your point earlier, COVID just shines a spotlight on it. You bring up broadband, but even just you see in discussions about testing as an example, there's so many challenges to underserved audiences to really being treated, being tested. And an example I just saw this morning as I was kind of digging into this a little bit is the idea of like drive-through testing, which is celebrated everywhere. It's just so convenient. Everybody can just, drive right up and get your test and off you go, which just assumes, of course, that people have a car and have the ability to drive somewhere, which immediately discounts such a huge part of the population. And it's just like you're talking about with the broadband. It's so often overlooked and unspoken to, and we just keep seeing this over and over. To what degree do you feel this is going to stick this time, Rob? It certainly is. COVID is unprecedented in terms of a health issue. For the last century, let's go back to the Spanish flu. It's obviously not something that's going away anytime soon. How confident are you that the impact that we're seeing on health disparities will actually help move the needle?
I'm hopeful, but if I'm the lessons in history, and as a historian, we always sort of, picture ourselves as that this is so new for us. But I'm reminded that in 1918, 2 things were going on in 1918. Not only the Spanish flu, but also you had some of the biggest race wars in the country. It was called the Red Summer. And so this whole issue of the context of having race relations and the pandemic happen simultaneously, and what we learned from that, we have already history to teach us. So when I think about, pandemics, I think a pandemic's running every 30 to 40 years. Now people say, what the hell are you talking about? And so I am going to be, and what I mean by that is 1918 was the Spanish flu. 40 some odd years later, we were dealing with polio. Unless memory serves me wrong, this is Jonas Salk and all the rest of that, right? 30 to 40 years after that, we were dealing with the HIV pandemic. And I know that they're, sort of different. And then now we're dealing here. So the crazy part about this is that how much we've been, students of history to actually be able to move things forward. So hopefully I'm hopeful, more hopeful than ever, that we've been awakened out of our slumber in some ways, that as we move forward, that there will be definitely some advancements. I'm also reminded that people get tired, that as a health system, listen, none of this stuff is new. Since 1899, from the first paper written by W.E.B. Du Bois that said, why did we have disparities and how did they impact health? The reality was you had issues in education, issues around policing, issues around housing, issues around health. So the reality is this is an argument that's almost like I was talking earlier about, being on a diet, right? You want to lose weight. So when it comes to disparities, I'm going to tell you something. We've studied up the yin yang, and we know that there's disparities. Since 65, right, we've had the same issues, okay? With the Rumsford report, we even know how to solve this issue. So it's just like being on a diet. You know, losing weight is good for you. There's nobody on the planet that doesn't say, well, losing weight and a couple pounds here and there is probably good for me with my sleep apnea, my hypertension, right? And you also probably have a drawer full of potential, very highly effective diets to choose from. The issue is will, right? So to be committed to losing weight, you actually have to stick and be committed to the medicine or the plan. The truth of the matter is, I am hopeful, because the truth of the matter is we don't have to find out what the problem is, and we don't even have to figure out what the solutions are. We have those. The issue is just going to be on an individual level, and as health systems, how committed are we to taking the medicine to getting it done? And that I have hope for.
Well, that's good. And so I want to ask you another question. And give it to us straight here. So in my kind of exploration over the summer, really trying to understand the social issues in a way that I don't think I ever really did, just reading a lot. And one of the things that just keeps coming back over and over is every time there's a step forward in terms of race relations, social justice, there's a step back, there's a pushback. And those pushbacks take different forms, right? So you had Reconstruction followed by Jim Crow, you had the Civil Rights Movement followed by the Southern Strategy. You had the election of the first African-American president, followed by what we have today. And even this summer, you saw just, survey results and research showing that so many people were behind, let's say, Black Lives Matter. And the George Floyd episode really woke a lot of people up. But then to your point, you see that kind of waning a little bit. You see a reaction to the 1619 project of, no, we actually need the 1776 project, which is the exact opposite. I'll just share with you, I got a text message, because I'm sure we're all getting this. Boy, I wish I could stop these, from a local politician, who I won't name, but the message just said, hey, vote for so-and-so. He's the one that will protect you from the destructive mobs. Now, if you saw where I live, Rob, that's laughable. It's not even thinly veiled what that is, right? So to the degree that we have a backlash, that we have that this is going to go one step back again, what are your thoughts on that and how that relates to what we need to do? Because we're not out of COVID-19, we're not out of the woods, we're not even close to it. And to your point, if we're really going to solve the health disparities and help these audiences, these underserved audiences, COVID-19, there's all these bigger issues that we have to keep moving forward.
Yeah, and you make a good point. I mean, human nature sort of says we're in much more of a dance pattern than forward movement, right? This is more like, doing, some sort of dance, 2 steps forward, 1 step back. I mean, and when you think of all those things, what was unique about those things or common, from the Reconstruction period to getting through all these other things to the, I always call it the 30-day of George Floyd, where for 30 days, all of us were on the same page. And then at day 31, all of a sudden we started retrenching, is fatigue. I think that what happens is people really, if we're going to make any movement forward, we are going to have to fight fatigue. And, as a former athlete, one of the things we trained for was, again, how to do the fourth quarter when you're out of gas, how to continue to do that, how to continue to move forward. But the second thing I think that we can learn from those mistakes of the past or the shortcomings of the past is, and I know this is going to sound crazy, but I'm taking a page from the WWF. I am. We don't because of fatigue and recognizing fatigue, we've not gotten good in partnerships where we can tag in somebody so that we can take a break, but we know that job is being done. I have not seen any health system that I recognize that actually has a system that says, we understand that fatigue is normal, right? The reality is the reason why there was retrenchment from the Reconstruction era wasn't so much that, Southern, people got tired. It was people in the North got tired, and other, right? So we all get tired. And I've recognized that now that there are some things that we've tried to actually act as if it doesn't affect us. And I think there's studies from Carnegie Mellon now that are kind of interesting and frightening at the same time. Some of you may have seen the 60 Minutes show that there's patterns that we have. First of all, we just have to be honest that we do have patterns, and that as people and systems, there is fatigue. So how do we fight fatigue? You can be superhero and actually learn how to do the fourth quarter drills and go beyond and push beyond, or we can just be more strategic. What partners do we need to bring in, and what partners has the authority and the resources to keep those programs going even when we fatigue? I don't know how else to do this. And I know that that's a global answer, but it's a big idea, but we've actually had so many things in the past that have failed that I think it was going to require a different way of thinking. Because I think everybody understood that the Civil War wound up being on right, not slavery, and they had Reconstruction, and Reconstruction was right, but there was an element that didn't. And the reality was the people who did push that over time felt and got to a point where they were like, okay, let's go on to something else. I actually think that we're going to have to figure out how, when we feel to go on to something else, there's somebody else that says, tag me, right? So I can continue to work. I don't know if we have those systems in place, but that's what I'm starting to grapple with, the big idea about how to get that in place so our health systems can continue to move along even when we as individuals get tired.
Oh, that's great. That's great insight. All right, last question for you, Rob, and then we'll let you go. What advice do you have for those at other health systems if they really want to try to focus on health disparities in their communities? What are the 2 or 3 things that you would just really recommend that they prioritize or focus on?
First, that there is an Amy Cooper in all of us. Let's get real now. Come on. Come on. Let's just get honest. There's a little Amy Cooper in all of us. And for those of you who don't know the Amy Cooper story, she was a white woman that was in Central Park with another guy whose name was, I'm blanking on his first name, but something Cooper, who was a Harvard grad, a bird watcher. This guy apparently sort of told her, listen, you got to have your dog, but your dog has to be on a leash. And then she used her position as a white woman to be able to say, I'm going to call the cops on you, knowing full well what all that was. Come on, let's get straight up honest. All of us have a little Amy Cooper in us from time to time, and you got to call that out. That's your first step. The second step is that to recognize that as we're talking about disparities is not always the people who live in those neighborhoods' fault. They're not genetically predisposed in most cases to have comorbid diseases. Let's get real in understanding that the comorbid diseases may be set up by structures that actually preceded them, in some cases by 80 or 90 years. What do I mean? South side Chicago, where's the greatest death? West and south side of Chicago. Greatest hypertension, west and south side of Chicago. Poorest food access, west side. That was set up by redlining, the 1933 Act, right? Or 34, 35 Acts of trying to do housing, but recognizing that there was redlining, literally excluding some people from certain areas, which means excluding some people from certain schools, that went on. There is actually what I call 21st century redlining actually going on now. Okay? So the very first step is to understand that things are still active and that we play a role. The second is to walk in now what I think a sense of humility. Why are we walking into neighborhoods telling them this is what's good for you as opposed to learning with them? There is a bilingualism of science that I talk about, the language of what we need to do when we talk with each other and the language we need to do to talk with people out in the community. You'll turn out that if you find the right frequency and the right language, people are interested in clinical trials. You just didn't ask them the right way. The second is that we have this thing called, that they are scientifically or health illiterate. Well, you know what? I went to a meeting, town hall meeting once, with an 87-year-old woman who sort of said, and I brought some of my scientists around, and she said, and my health leaders, vice president of blah, 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 grand poobah this, right?
Right.
And they went into the community on the west side of Chicago. And this 87-year-old woman sort of said, Dr. Winn, I don't know how many times they keep saying illiterate. We illiterate. They illiterate too. They don't know nothing about us. And it was true. So there is an appreciation now of how are we going to bring the community, not voice, because people say, well, let's bring them at the table. I remind all of our health system leaders that just because, centerpieces are also at the center of the table, and they're beautiful and everyone sees them. And when the meeting is over, you throw them in a damn corner and you don't think about it again. Let's stop talking about community outreach and engagement, and let's start talking about community involvement, where the community input can help refine, and in some cases, help you define the approaches that you need to take. Now that takes effort. But the reality is, just like lifting weights and just like getting in shape, you can't do it without exercising that. And in beginning, you also have to have patience and grace. And I'll end with the last one, grace. Grace matters. To have an abundance of grace for yourself, to know that shit, come on, man, you're not gonna get all this right, nor should you be expected to. That's just dumb. But I do know that in the travel, in the exercising of trying to become a more perfect health system, that by employing these things, understanding the Amy Cooper in us, understanding the abundance of grace, and understanding the humility to think about bringing people to integrate them into your system so you learn better, we just might have a shot at getting there. At least that's what I hope.
Well, that's a great, great thought to end on. Really, really positive. I can't thank you enough, Rob, for joining us today and for being patient with terrible technology.
But you know what? I say this, we're in an era of not only high tech, but high touch. And I could feel your energy of wanting to do this. So that high touch part really, kind of kept this show together. So I appreciate you guys for putting this on and having me and giving me the opportunity to talk to you today.
Well, we appreciate the time. We know that it's valuable. We know you're doing such great stuff. And who knows, we may ask you back. I think we're going to get a lot of people who would love to hear more from
I hope
you.
I'm not wearing everybody out. My mom used to say,
I
I'm
don't
not
think
wearing
so.
everybody out. It's not, in fact,
I
I
feel
did
like
not
we're just
drink
getting
coffee
started.
today. I stopped my cup of coffee today knowing I was going to be on this show. I didn't want to be too hyped up.
No, I think I feel like we're just getting started and we have to stop. So that's what I mean. We may have you come back for part 2 down the road. But again, thank you so much for joining.
Thank you. Thank you.
Chase, dude, thank you for keeping it together while I'm audio only. Appreciate that.
Absolutely. Thank you, Robert. Really enjoyed the conversation.
No, thank you for giving me the opportunity. Appreciate you guys.
Yeah.
If you would like us to cover something on this show, let us know. You can put it in the chat tool right now on Zoom or email us at nonormal@thinkrevivehealth.com. Again, we will have a recording of this show up before the end of the day on our website at thinkrevivehealth.com/COVID-19, or watch for it on iTunes or wherever else you subscribe to podcasts. What a show. Thanks for joining us. Until next week, good luck out there in the no normal. We'll talk to you then.